Well, hi everyone. I'd like to start by thanking PAHO and the organisers of this meeting for inviting me to be here. I must say I'm finding this absolutely fascinating to learn about the various developments in medical education here in South America and some really exciting initiatives. So thanks very much for the opportunity to be here. I've been asked to be the first speaker in this group of speakers around clinical education, and I'm going to speak according to this theme: social accountability through distributed community engaged learning, and talk about the Northern Ontario School of Medicine in Canada. I'll begin by setting the scene, giving you a sense of Northern Ontario, then describe the setup of the school and our academic programs, and then conclude with presenting just some of the early outcomes of Northern Ontario School of Medicine. This is the disclosure, nothing to hide except a great passion for medical education. I guess I'm not hiding that either. Okay, this is Canada, and yesterday you had a presentation that was more about this part of Canada, which is the province of Quebec. Today, or right now, we're homing in on this province, which is called Ontario, and Northern Ontario is this area here. So these are the Great Lakes, and that's Hudson Bay and James Bay, and so Northern Ontario is that large area between the two. Well, looking more closely, this is Northern Ontario, and you'll see that most of it is black. This is a map of Ontario that came out of the 2006 census, and essentially what it shows is that most of Northern Ontario is quite sparsely populated. We have a total population of just under 800,000 people and a total area of over 800,000 square kilometres. This is Germany and France put together. We have two larger population centres. Thunder Bay is here, and Sudbury is there, and they're about 1,000 kilometres apart. We have three other communities that are 50,000 population or more. So Sault Ste. Marie is there, and North Bay is here, and Timmins is there, and all of the other communities are 10,000 or less. So small communities, large distances. The economy of Northern Ontario is resource-based: mining, forestry, tourism. So subject to the ups and downs of the world economy. And this is quite a contrast to the rest of the province of Ontario. So this is the southern part of the province, 12 million people in what looks to me like quite a small area. And that's the manufacturing heartland, not just of Ontario, but really for the whole of Canada. So much more secondary industry. So that's Northern Ontario, and the health status of the people of Northern Ontario is generally worse than the rest of the province. So these light green bars are the districts in Northern Ontario. These are the districts in Southern Ontario, and that's the province in a whole. So you can see that the health status of people in Northern Ontario is generally worse than the rest of the province, and there's always been a shortage of doctors and other health professionals in Northern Ontario. So in that context, in 2001, there was a widespread community movement across Northern Ontario which said, if we're ever going to turn around the shortage of doctors and other health professionals in Northern Ontario, if we're ever going to improve the health status of the people and the communities of Northern Ontario, we need to have our own standalone Northern Ontario School of Medicine. And so that's how the Northern Ontario School of Medicine came into existence. I began as the founding dean in 2002, and the school was established actually as a not-for-profit corporation. The school serves as the Faculty of Medicine of two universities, Lakehead University in Thunder Bay and Laurentian University in Sudbury, and the way that the corporation is set up is that the two universities are the members, like the shareholders of the corporation. We have our own board of directors, and in the documents that set up the corporation, set out what we call the social accountability mandate. That's a commitment to be responsive to the needs of the people and the communities of Northern Ontario, with a focus on improving the health of the people and the communities of Northern Ontario. There's also a commitment to innovation. Our Board of Directors, the members of the Board of Directors, are drawn not only from the universities and the School of Medicine, but also from community groups and organisations across Northern Ontario. So right at the corporate governance level, there's a direct connection between the communities and the Northern Ontario School of Medicine. The education and training activities of the school are based on research evidence which shows that the three factors most strongly associated with going into rural practice after education and training are, first of all, a rural upbringing, that's having grown up in a rural area. The second factor most strongly associated with going into rural practice is positive, and I emphasise the word positive, clinical and educational experiences at the undergraduate level. And the third factor associated with going into rural practice is targeted training after graduation, residency training that prepares the physician to practice in the rural setting. So in Northern Ontario, we do all of that. In fact, we have, as was described before, that cradle-to-grave concept, the life cycle of a physician in Northern Ontario. It's not on this slide, but we have pipeline activities, as was described before, starting even in the elementary schools in the First Nation communities, the Aboriginal communities, and certainly in the secondary schools, encouraging the young people in Northern Ontario to see a future for themselves that might include becoming healthcare practitioners and particularly physicians, so that they have the motivation to continue in school, to graduate from school, and then into university and medical school and beyond. And I should explain that in Canada, as in the United States, that medical education begins after a university degree. So all of the students that we recruit have a university degree, and then they move into the undergraduate medical education program, which in our case is a 4-year program for an MD degree, and I'm going to say more about that. As you can see, we also have residency programs. We have family medicine and 8 other general specialties. We have an extensive program of continuing education, professional development, and we already have other programs in other health sciences like producing dietitians, physician assistants, and so on. There's a strong emphasis on interprofessional education, and because of our distributed nature, we rely heavily on a digital library service. We also have a growing research program, and our research is guided by the social accountability mandate. That is, addressing research questions, the answer for which makes a difference to the health of the people of Northern Ontario. Before I say more about the MD program, just to dwell a moment about our selection and admissions process, and there was some discussion about this by previous speakers. This slide shows the 6 years of applicants and then admissions into our school. You can see that it's very competitive. This works out at 35 applicants for every place. We have 64 students in each class, and we have a selection and admissions process which favours applicants who come from Northern Ontario or from other rural, remote, Aboriginal or Francophone backgrounds. Francophone are people for whom French is their home language. Aboriginal people are the original Canadians, the native people of Canada. And so with our selection and admissions process, we aim, because of our social accountability mandate, we aim to reflect the population distribution of Northern Ontario in each class, and you can see that we've been quite successful. 91% of our students have grown up in Northern Ontario. The other 9% come from remote and rural parts of the rest of Canada. So it's rare to have a student in our class who comes from a city outside of Northern Ontario. You can see in terms of our other our specific populations of special interest that about 40% come from remote or rural backgrounds. That's about right for the population distribution of Northern Ontario. You can see 22% are Francophone. That's about right for the population of Northern Ontario. 7% Aboriginal is low. The population distribution of Northern Ontario 10 or 12% of the people are Aboriginal people, and the lower percentage of Aboriginal people reflects the small number of applicants that we get who are Aboriginal people. So out of 2,000 applicants each year, 40 are Aboriginal. That's 2% of the application pool. Now you can see with the supports, encouragement that we provide, that our Aboriginal applicants are more successful, and 7% of the students are Aboriginal. But nevertheless, what we need is the pipeline to be starting to increase the number of Aboriginal applicants, the size of the applicant pool, so that we can lift the numbers up to the 10 or 12% that we would like to see. Now, I also wanted to point out, so remember that our students that we take in have a university degree, that the way that we look at their academic performance before coming into medical school is by what's called a grade point average. That's GPA, is grade point average. And our students on entry to our medical school have a grade point average around 3.7, which is the same as the other medical schools in Canada. In other words, to have an admissions process which favours applicants from Northern Ontario and similar northern, rural, remote, Aboriginal and Francophone backgrounds, we have not lowered the academic standards. Distributed, community-engaged learning is the distinctive model of medical education and health research, which we have developed for the Northern Ontario School of Medicine. And you can see that there are three key elements to distributed, community-engaged learning. The first is that the teaching learning activity, the education, is taking place in multiple locations distributed over a large area, sometimes at the same time, synchronously, and sometimes out of sync, so asynchronously. In order to do this, we rely heavily on electronic communications to connect our multiple sites, and we rely heavily on our interdependent partnerships with the communities across Northern Ontario, and I'll say some more about that in a moment. This is a visual of distributed community-engaged learning. You can see that in Northern Ontario we have over 70 different sites where our students and our residents may undertake part of their clinical learning, and the shapes and the colours reflect different parts of our 4-year MD program. So in first and second year, our students spend most of their time on the university campuses in Thunder Bay and Sudbury, and they have classroom learning and so on, and I'll say some more about that in a moment. But they also have one rotation away from the campus, and that is to Aboriginal communities. So these green circles are Aboriginal communities. Many of them are known as First Nations, which are self-governing communities of Indigenous or Aboriginal people. And these ones are very remote. You can only get there by airplane, except in the winter when they cut ice roads that's how they bring in the heavy equipment and supplies. So very remote communities, and the size varies from 200 to 2,000 in terms of population. So in the first year, our students have an Aboriginal community experience. It's an immersive experience, and they're there to learn from the community about the history, the tradition, the culture, the social issues and the health issues of the community. So that's in first year. In second year, we have two what we call integrated community experiences, also each of 4 weeks, where the students are attached to physicians and in fact to the whole health team. So these are clinical experiences, and these are in the small, remote and rural communities. So there you can see the blue diamonds that are spread around Northern Ontario. And so that's in second year, 2 4-week integrated community experiences. And then in third year, the students have what's called a comprehensive community clerkship, and this was mentioned yesterday. This is where our students are not in Sudbury or in Thunder Bay, but in one of 13 large rural or small urban communities, and they live in the community for the whole academic year, which is 8 months, and essentially they see patients, and they're based in family practice. So they're in the primary care setting and they see patients, and the first patient might be a child That's paediatrics. The next patient might be pregnant. That's obstetrics. The next patient might have a surgical problem. So the learning objectives for our comprehensive community clerkship are just the same as in the other four-year medical schools and the third year of the other four-year medical schools in the 6 core clinical disciplines. So the learning objectives in the 6 core clinical disciplines are just the same: internal medicine, surgery, paediatrics, and so on. But the learning environment is very different. Our students are learning their core clinical medicine from the community, family practice, primary care perspective. And their main teachers, main faculty members, are family physicians. In fourth year, the students are then back in the tertiary care hospitals in the regional centres of Sudbury and Thunder Bay. And that's the first time that the teachers have direct teaching by the specialists and subspecialists in those tertiary care centres. So that gives you a quick overview of our MD program in terms of the clinical learning, except I didn't mention that in first and second year, when the students are on in the university campuses, they're actually starting to learn their clinical skills. So every week there's a half day right from week 1 of year 1 where the students are learning their clinical skills, and we have community members who are brought in. They come in and they're trained as standardised patients. And so right from the beginning of the program, the students are learning those skills of interviewing and physical examination with the help of community members. I should mention also that in first and second year there's another half day every week of what we call community interprofessional learning, and this is where students go into a range of health and welfare services, about 1/3 where physicians are main service providers, about 1/3 where other health professionals are main service providers, and about 1/3 that are really community or welfare services. So that's community interprofessional learning, half day a week in the first 2 years of our program. In our program, there are quite a number of curriculum innovations. In the classroom, the students are learning in small groups, what we call patient-centered, case-based learning, and this is really a development from problem-based learning. The cases are complex real-life scenarios set in real Northern Ontario communities. So the students are learning in the classroom as if they're going to be practicing in Northern Ontario. So there's a strong emphasis through our whole program of learning in context. There's also a focus on longitudinal learning, and in fact, we don't have any courses or subjects in the conventional sense. We don't have anatomy, we don't have biochemistry, we don't have physiology. We have 5 themes that run through the 4 years of the MD program. Theme 1 is Northern and Rural Health, and that's obviously about the health issues, health care and practice in Northern Ontario. The second theme is personal and professional issues in medical practice, and the third theme is social and population health. The fourth theme is foundations of medicine, and the fifth theme is clinical skills in healthcare. There's a strong emphasis throughout our program and for the whole school really of working in close collaboration with communities, and I'll say a little bit more about that. And I've already described how we have distributed learning, which is in a large rural area, and so very much rural-based education. And integrated clinical learning is the concept of team teaching and team learning. So not just one doctor having the main teaching responsibility, but actually a team of doctors and other health professionals together in a clinical setting, teaching a team of learners, medical students at different levels, residents at different levels, and other health professional students as well. So team teaching and team learning, and I'll say a bit more about that in a minute as well. So community engagement really is the centrepiece of the Northern Ontario School of Medicine program, and the communities are interdependent partners with the school. The communities certainly have a major role when the students go to these communities, especially in third year. They have a major role in making the students feel at home in the community, and of course there's a future recruitment opportunity for these communities, because if the student and the student's family like the community, then maybe they'll come back and serve the community in the future. So there's that. But in addition to that, the community actually contributes to the learning for the students and helps the students to understand the social determinants of health at the local level. I should mention also that the doctors and the other health professionals in these communities are faculty members of the school, and all faculty members of the school are faculty members of the school. We don't make a distinction between full-time and part-time and sort of campus-based or hospital-based and community-based. A faculty member is a faculty member is a faculty member for Northern Ontario School of Medicine, wherever they may be practicing. And we rely heavily on those physicians and nurse practitioners, other health professionals who are in these communities, where our students, and particularly in the third year, that's the year where the students make the transition from being classroom learners to clinicians, that principal clinical year, we're heavily reliant on those community practitioners as our faculty members for the school. The involvement of the school with the community goes further than that, because the communities are increasingly becoming involved in other programs of the school and seeing opportunities to actually strengthen the community as a result of the relationship with the community. So I was asked to particularly focus on clinical learning, so I want to emphasise just a few themes. Clearly, the way that we have set up our program, there's an emphasis on what's now called ServiceLearning, where the students are experiencing for themselves the community and the needs of the community and learning to be responding to those needs, and very much learning in context, as I mentioned before. I mentioned integrated clinical learning, and I just want to emphasise that an important element of that is interprofessional learning. So we see that our graduates are more likely to practice as members of the whole health team if they learn as students with students across the health disciplines than the students in the whole health team as well. So that's an important element of integrated clinical learning. Longitudinal learning also we see as very important, that the students are, particularly again in the third year where they're in the community for the whole academic year, they really become part of the health team. And in fact, our students talk about going to work rather than going to study. There's a whole different mindset. And they benefit from the ongoing relationships that they develop, both with the patients and with the clinical teachers. And over time, the clinical teachers get to know them and see that they're gaining in their knowledge and skills, and so they're able to take more responsibility and learn more. And really, by the end of the third year, our students are functioning with a higher level of knowledge and skills and clinical confidence and competence than students at the end of third year in other medical schools. So I just want to share briefly some outcomes to give you a sense. The School of Medicine was we had our official opening in 2005, and it's a 4-year program, so we had our first graduation in 2009. That means we've had 4 graduating cohorts. Now in Canada, just like in the United States, after graduation, our graduates go straight into postgraduate education, residency training, and there's a national match. And for 3 of the 4 years, all of the students in our class were matched in the first round of the national residency match. And in the second cohort of students, only 1 student wasn't matched in the second round. Now, we take this to mean that the residency program directors across Canada want to have our students, our graduates, in their residency programs. Another way of comparing how our students go to other medical schools is there's a national exam in Canada. That's the Medical Council of Canada exam. Part 1 is a written exam, which the students sit in their final year of medicine, and our students have been performing consistently above average in that exam, and in fact right up the top in the section on clinical decision making. The second part of the Medical Council of Canada exam is a clinical exam which the residents sit in their second year postgraduate, and you can see from this slide in 2 of the last 4 years, the combined score of our residents has placed Northern Ontario School of Medicine #1 out of the 17 medical schools in Canada. But the question that people in Northern Ontario asked was, does this mean I'm going to have a doctor? What is the career direction that our graduates are choosing? And in fact, 61% of our graduates have chosen mostly rural family medicine, and this is double the national average for Canada. 33% other general specialties. So 94% of our graduates are now in the process of becoming general specialists, including family medicine, and only 6% subspecialists like radiation oncologists or dermatologists or plastic surgeons. So this proves that if they want to, our students can be matched into these highly competitive subspecialty programs, but that's not what most of them choose to do. We do know, because we've had family medicine residency training for over 20 years in Northern Ontario, that 65% of the doctors who train in Northern Ontario are still practicing in Northern Ontario, and we have, as I mentioned already, similar sort of experience with our dietetic internship program and our physician assistant program. I want to also just stop for a minute and talk about the socioeconomic impact of Northern Ontario School of Medicine. So in 2008-2009, we did a study, or at least the Centre for Rural and Northern Health Research on our behalf looked at the socioeconomic impact of the school. In that year, the budget, that's the money provided by the Ontario government, was $37 million, and you can see that the level of new economic activity was between $67 and $82 million, which is like a 2-for-1 multiplier effect. And there was economic growth, that's new jobs, and economic development, that's new job categories that wouldn't be in Northern Ontario without having the School of Medicine. So that's good, but the social impact findings were even more interesting. Yes, the hospitals and the health services and the universities reported improved recruitment and retention for the universities, faculty members and students, for the hospitals and health services, physicians and other health professionals. So improved retention recruitment, that's good. But what was really interesting was the communities. So if you remember, 2008 wasn't a great year for the world, the global financial crisis. So the study was done in 2009, and it was essentially interviewing individuals and small groups in these communities. And you would have expected in that situation for people to be pessimistic about the future. That isn't what the researchers found. They found that the people were optimistic about the future, and they connected that to Northern Ontario School of Medicine, not just in terms of access to doctors and healthcare, but there was a sense of empowerment, because these people had been part of that community movement that had pushed to have the medical school, and now not only is there a medical school, but it's a success. So there was a sense that if we can do a successful medical school, we can do anything. And in fact, both universities, Lakehead University, Laurentian University, there are signs of that. Lakehead University next year will open a law school, Laurentian University an architecture school, and without the success of the medical school, I don't think they would have had a chance of having approval to start new professional schools of that sort. So, already there are signs, I think, positive signs in terms of outcomes, as I've presented, and it's not just about more doctors and health professionals, but it's a kind of doctors, generalists who are members of the whole health team and responding to the needs of the people and communities that they have the privilege to serve, as well as research and academic developments and economic developments. Before I close, I just want to highlight that just back in October, 6 weeks ago, we hosted a conference. It was actually 5 world conferences in one, which was known as Rendezvous 2012. And you should have received in your package some information about Northern Ontario School of Medicine, and also the Thunder Bay Communique, New Ways of Thinking. This was the conference statement that was put together by the conference participants. There were over 850 conference participants. And it's new ways of thinking about community participation in education, research and service. And I want to draw your attention to the second last page, which really sets out commitments by those of us who are in universities and academic institutions, and some of the examples include a commitment to have communities guide us in the implementation of health professional education that addresses their needs, to develop programs and new methods of education that maximise the immersion of students in communities throughout their training, to work together internationally to share education, resources and research tools openly, and the last one, to provide transformational educational opportunities that maximise the length and strength of relationships with patients, supervisors and communities, and create authentic workplace learning and identity formation. So I commend to you the Thunder Bay communique as well worth reading and well worth joining us in making a commitment to implement the recommendations in that declaration. Just some references if you want to follow up what I've been talking about in terms of Northern Ontario School of Medicine. So drawing this together, I have set the scene of Northern Ontario and presented the School of Medicine and some early outcomes of Northern Ontario School of Medicine. In conclusion, I think it's fair to say that there are early signs of success, that Northern Ontario School of Medicine is contributing to improving the health of the people and the communities of Northern Ontario. Thank you.